Marco Benavides.
Hi, my name is Roddy.
And I am Elizabeth Fritz.
We're here to propose studies that would further the treatment of addiction to prescription opioids.
This is a prevalent issue in a lot of medical communities and can quickly become a devastating situation not only for the person dealing with this illness, but also their loved ones.
There are treatment plans available, and right now the one that's the most successful is called opioid agonist therapy. And although it has shown positive outcomes, there's still a considerable portion that does not successfully complete treatment, and even cases where the addiction worsens to the point of initiating heroin use.
When trying to find a way to treat such a dynamic illness like addiction, there are so many angles that it's easy to miss some parts and just try to treat the symptoms. But in order to start improving, we need to look at the root of the problem. We need to look at the pain. The number one reason why people report starting their use of prescription opioids is to be able to treat chronic pain, most commonly in their back or their neck. This underlying pain prevents a lot of addicts from fully recovering. In fact, high pain volatility is one of the few things that can predict an unsuccessful treatment. In order to treat this pre-existing pain and by proxy treat the addiction is to develop a non-opioid medication regime to be administered along with standard opioid agonist therapy, which is a system designed to wean people off the drugs slowly. To determine the best medication regimen, a randomized control trial will need to take place with a sizable group of at least 50 participants over an extended period of time to account for changes in perception and tolerance of the drugs administered. Using quantitative methods, the results from this study would be recorded and graphed to develop an algorithm for dosages in future cases and lay a foundation for an abuse deterrent system. The question I'm asking is, would focusing on treating pre-existing pain with non-opioid medication lead to higher success rates in addiction therapies?
It is true that pain is the main reason why people begin taking opiates. However, there is some doubt as to the reality of their pain. It is very possible that the chronic pain they experience is a psychosomatic symptom of their emotional distress. The pain does need to be addressed, but if there is no actual physical basis for it, then there's a possibility that adding additional medication would worsen addiction, even if the medication was not an opiate. The study proposes to observe different methods of non-medicated pain management therapies to determine if the addition of these methods to opioid agonist therapy increases the likelihood of a successful outcome. This research would focus on two main groups. The first group of participants would be control and would only attend opioid agonist therapy. The second group would be the people receiving additional talk and physical therapies. It would consist of a set of subgroups focusing on specific therapy methods. There would be some quantitative procedures to be able to view the progress of individuals in their treatments, as well as an overall view of the success of each treatment. But the majority will consist of qualitative methods, including interviews of the participants and observations of their behaviors. So essentially what I'm trying to find out is, if treatment focuses on the alleviation of emotional distress and the pain utilizing non-medicated procedures, would that improve recovery rates of those addicted to opioid medications?
There are arguments for both sides. On one hand, medication could treat underlying pain, but adding more drugs could worsen the addiction. On the other hand, talk therapies could relieve emotional distress, but might not effectively treat the underlying pain, even if it is psychosomatic. Now we get to the problem that even if we do find the best medication regimen and the best therapy plan, which one is better overall? Which one has the most successful outcomes? My study would consist of a secondary analysis of the data and observation of Marco and Dylan studies in addition to the concentrated efforts to evaluate long-term outcomes. It would start with the previous data found, what non-opioid medication treats the underlying chronic pain successfully, what therapy programs have yielded the best results, and then a new procedure would be put in place to observe these methods side by side. What I want to establish is whether treatment with an intensified focus on a non-opioid medication plan for pre-existing pain or a natural pain management program contributes to therapy and leads to higher success rates.
Ethically, all of these studies involve very similar responsibilities. Every participant would be fully informed and treated as an autonomous individual. They would be randomly selected with the only qualifying factor needing to be that they do have to have pre-existing chronic pain.
They would be informed of the rights as participants, including their right to withdraw at any time, as well as alternative options for treatment.
The beneficence of these studies are enormous. There is very little risk involved, seeing as every individual will at the very least be receiving treatment that has been shown to be effective, and although there is some concern that their conditions might worsen, the benefit of improving the quality of care that people would receive outweighs the potential risks.